Dear friends, I'm Dr. Tatiana. I'm professor of the Department of Propedeutics of Internal Medicine of the Medical Dnipropetrovsk Academy. And I'm glad to invite you to our virtual lecture audience to present you the short lecture as to auscultation of the heart, the main signs of normal and pathological tones and heart sounds. So let's go. And for the first, I want to announce the great idea of the ancient famous philosophist Plutarch. Learn to listen and you can gain benefits. So, auscultation, what is it? It is one of the main physical methods of examination, and it is the most informative for your conclusions about the status of the patient. So, auscultation of the heart is the method of examination of the heart structure and function based on listening of the sounds which accompany heartbeats. So, what about the history? The history is that Hippocrates here may be the heart when he listened for the sounds of the lungs. But the first who noticed to hear the heart was the ancient Greek physician Arete in the 2nd century before Christ. In 1616, William Harvey described the presence of two tones during listening of the heart. And at the end of 17th century, Robert Hooke at the report in the Royal Society said, "I'm absolutely could hear the beating of the human heart. Probably it is possible to detect the action of the internal parts of the body by the sounds which they produce." So what we have the next historical event, it was the great person, French medicine. So great scientist and physician, René Théophile Hyacinthe Laennec, who in 1816 announced this his practice as to the hearing, the lungs, and the heart by the indirect method with the stethoscope. So look here, and you see there the examples of technical evolution of stethoscopes year by the year. And now we use such a type of classic Rappaport stethoscope from 1940. And as you see here, Littmann proposed a more perfect type of it, but you don't need the watch here as the second head of stethoscope. You have to buy the stethoscope with the diaphragm and stethoscope, which can be useful for you while your education and real clinical practice. So, but you have to know also what is the best. Today we have such a type of stethoscope, and as you see here, one membrane but by the pressure of the head of this stethoscope, slightly or stronger, you may receive information about low and high pitch sounds from the function of the heart. So let's go, but it's for the high level classification types of stethoscopes and for qualified professional cardiologists. So let's go on, and you see here different types of educational abilities as to understanding the heart problems of patients. So you see different age students wants to be educated as to hearing the sounds of the heart, how to better auscultate. We will go and understand that the piano players may identify the heart melody by this scheme, and you may try to do it, but you have to understand also that every heart has his own melody, and you may receive the practice of that. And the next important idea is your ears are better than any test, and they don't cost the patient any cents. So it's the shortest way to your conclusion as to the problems of the heart of the patient, how severe are they. So to understand the heart sounds, you have to know the physiology and pathophysiology of cardiac function and cardiac cycle. So here is presented systolic period of cardiac cycle, and you have to know the what it consists of atrial contraction, ventricular systole, and you see here the different types of contraction and hiring of pressure in the left ventricle, for example, as represented here. And you see here also the output of the left ventricle, and rapid diastolic feeling starts the diastolic period. You may imagine it because it isn't here, but we will go to another picture and try to understand the timing of the heart sounds. So let's look for there, and rising of ventricular pressure and contraction of the ventricle starts the first systolic sound, as you see here after the mechanical contraction of the heart. So the next, it will be systolic period, and it will finish by hearing of the second sound, which we name as diastolic sound, because it starts the diastolic period. And as you see here, it may be free, clear of sounds, but sometimes you may hear the third sound in some normal or pathological cases, and maybe fourth sound, and it may appear only in pathological cases before the next systolic contraction of the ventricles. So let's go on, and how to identify on phonocardiogram, as you see here, the first and the second sound, and you may applicate these sounds on the ECG shape and complexes, and you see that the first one is after the complex of QRS, which represent ventricular electricity while systolic period. So it will start the contraction, and at the end of T wave, you receive the information and shape of some signs of second sound, which we name diastolic, and up to the start of P wave of the next electrical contraction, you will see the diastolic period, and here you will identify some additional maybe sounds. Let's go on. So systolic S1, diastolic S1, S2, and we will go to understanding heart sounds origin. Some theoretical ideas. So as you see here, 1, 2, 3, 4 components of the first sound, and you can see here what elements and structures of the heart can be involved into this process. And for the first, it will be atrioventricular valves and aortic valves. It will be valve component, then it will be muscular component, and it will be the waves of the blood flow, and as you see here, it will be also vascular component, which will be contain the first sound. And as to this second sound, diastolic one, you see here that the semilunar valves of aorta and pulmonary trunk, and the walls of these big arteries are involved into this process. And what about the third one? As you see here, at the early diastolic period, it will be shaking of the left ventricle for the first, as to the strong blood flow from the contraction of the atoms to inflow the left ventricle for the first. And here is the most important information as to the first sound, ventricular systolic sound, and you see here muscular component, fluctuations, you see component of atrioventricular valves, fluctuations, and you see here during their closing, similar valves fluctuation during their opening. But what you have to know as to these components, you have to know that valves are silent when they are closing or opening. And for the last ideas from the scientific pages, we can read that these components of the valves associated with their fluctuation as the same of muscular and vascular fluctuation, while closing and opening valves are associated with the hydrodynamics shock and hydrodynamics waves in the cameras of the heart while contraction, and even they forms the sounds which we name systolic S1. So, and also you see here valve component and also fluctuations are associated with this period of heart function. So let's go on, and once more you may see here all components of the first sound, and we will go next to the second diastolic sound. And what will we see here? We will see here also 4 components. There is muscular component of semilunar valves, and you see here the fluctuation of the walls of the great arteries and the same atrioventricular valves fluctuation during their opening also plays some role in the forming of second sound. But you have to understand, it's not slamming of the valves, it's their fluctuation, you see? So let's go on, and the aims of auscultation. The intensity of first sound at all points, the intensity of second sound at all points, and then characteristics of any other systolic sounds, extra sounds, or characteristics of any extra sounds in diastolic period of cardiac function. So what is the technique? We have to use our stethoscope, and we have to know what diaphragm for and how we use it. Press tightly to the chest wall. All points of auscultation we have to examine. High-pitched sounds we can hear, and first and second tones or sounds, and noises at the mitral and aortic insufficiency problems, and pericardial rub also. What about the bell you see here of the stethoscope? It's different. Do not press strongly. The heart of the heart we can hear at the apex and lower border by this device, by this head, and lower border of the sternum. Low pitch sounds will identify by the bell, the third and the fourth tones, and noise at the mitral stenosis. And here you see how we have used 2 heads, diaphragm and the bell, and let's go on for the transmission of sounds and murmurs. So in the center of this picture, you see anatomical position of the valves and ostiums. So, but these arrows shows us where we have to auscultate these valves. And as you see here, mitral valve, we will go to auscultate in the fifth intercostal space near medial-clavicular line, or for the aortic valve, we will go to the second intercostal space near the sternum right side, and symmetrically left side for pulmonary trunk structures. And then you see here tricuspid area, and there we have another point for additional auscultation of aortic area. But you see here, not points, but areas. What does it mean? How we have to auscultate and what we have to know. Let's look for that. And the first point for auscultation we represent here at the apex. Then we go to the base of the heart, right side. Then we go to the left symmetrical area. Then we will go to the tricuspid point or area here in the middle of the body of this of sternum. Right side or left side, it's also normal. And then you see here the fifth point, Ebb's point, in the position of the third or fourth rib. And what you have to know once more, there are points and there is the algorithm how to auscultate. But look here, you see here that we underline that all structures are involved into the first origin sound and to the second one. So there will be the areas. Look here, the area of left ventricle, and you see here the larger area than even this point. Then you will look for aortic area, for pulmonic area, for right ventricle or tricuspid area, and you see that they are larger than the points we auscultate. So let's go for the next point, and here I want to show you Ebb's point, and it is additional point in the area of aortic auscultation. So it is additional point, fifth points for it. So you have to know also the rule of number 8. Why? Look here, you start to draw 8 from the apex, go to the base of the heart, and then go down, and you receive information from all 5 points. But look here, English language books propose us mnemonic rule. All people in Joint Time magazine. So, and for the first starts from the base of the heart and go down. What to do? How to understand? What is the algorithm? What you have to do? The English language books tells us not to be trouble of that, and you may start from the apex or from the base, and it will be the equal for information. And next, I want to stress for you that you have to listen at each area for heart sounds, first, second, the basic, or maybe there are variations, or maybe additional sounds. Let's go on to understand the algorithm of auscultation. So you see first, second, third, fourth, and fifth points to represent the same areas. So we start from the left ventricle area and then go to the base to auscultate aortic area. Then we go to the pulmonary trunk area and then to right ventricle area or tricuspid valve. And the last, we have to listen for the fifth Ebb's additional point for aorta signs. So let's look here, and you have to know in what positions you have to identify the melody of the heart. So you have to think detailedly where to start and where to go. In the line position, which will be classic, and it will be 30 degrees on the back, lying on the back, And then you may use additional positions, land on the left side, sitting or standing, to understand better the problems. So the positions for auscultation, what are they? We start from the first by diaphragm. And you see here that you may go next to the base of the heart, and next you may use additional position of the patient with the bell to hear better third sound. And as you see here, you may identify better auscultation sounds on the base of the heart by forward position of the patient to understand the problems of aorta root. So the first step of the dynamic auscultation of the heart is to understand written rate. So let's go on, and you may start it from the apex of the heart, and you have to understand where is the first sound. So you may use your left arm and your tips of the fingers in this position to understand where is the first sound, because the wave of carotids will be near the first sound and durate from S1 to S2. So what you will hear? You will hear mnemonic type of melody, and it will be labbed up, labbed up. Why so? Because the first sound is longer and louder on the apex of the heart. So labbed up, labbed up. And then what you have to understand that the systolic period is shorter than diastolic. So it will be labbed up at the apex. And if you hear additional heart sounds, it will be lab-dab-da, lab-dab-da, lab-dab-da. It will be the melody, and you have to train to hear that. So it's really easy, lab-dab, if you will be serious and won't think about the evening party. So what is S1? Once more, you may identify S1 by putting your left hand tips of the fingers up to the impulse maximum and listening in the same time the apex of the heart of the patient. Or another way we underlined previously, you see here, we try to identify the carotid wave and auscultate in the same time to understand S1. So let's go on, and lab-dub on the apex. So additional sounds, open and snap, systolic injection, click, prosthetic, heart wave, waves, then pericardial friction rub, and so on. But what are the rules? For the first, you have to identify for yourself. First and second sound are different. So first and second have specific areas to be here louder. S1 period is usually shorter than S2 to S1 period, diastolic period. And the peaks of carotid pulse wave falls on the period from S1 to S2. So it's very important to you to be effective. Then we will turn by diaphragm where? To the base of the heart. And we will hear the lab-dub, 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 or maybe lab-dub, lab-dub. So S1 and the S2 will be equal more often here. As to compare with the apex, lab-dub, lab-dub. So let's go to the systolic clicks or additional extra sounds through the systolic period. You will hear them by diaphragm, but you will receive this information in your textbooks. Let's go on. And you have to know that systolic extra sounds may be normal, but diastolic extra sounds never. So open snap is typical, so you see it here in the early diastolic period, and it is typical for mitral stenosis. Then you see here Third sound, it may be normal, but more often you have to pay attention to the pathological, its status, and it will be later than OS, and it will be the sign of heart failure, maybe. The same will be S4, but you see here that it is before, nearer, and before the next S1. So it is pre-systolic diastolic sound, and it won't be ever normal. It in all cases is pathological. So let's go on, and this box of information you have to identify detailedly in your textbook. So I want to show you this perfect picture. So here is left side normal, and there is a pathological picture which tells us about the origin of S3. So you see the enlarged cavity and a thin wall of left ventricle and early diastolic period, and blood flow falls at this thick wall of left ventricle, shaking it and forms S3. So it will be lab-da-da. And what you have to know that it may be compared with the Kentucky, and it will be hearing by lab-da-da. And as you see here, it may be in normal cases at the person's younger than 35, and more often older, it will be the sign of heart failure, and it tells you about heart crying for help in the case of weak left ventricle more often. So let's look for S4, the same normal, and presystolic S4 tells us about now the problems. It will be atrial gallop and atrium S4, when the atrium tries to infill the small cavity of hypertrophic left ventricle, and it is loud by pressure and forms such a sounds you to recognize, and it will be compared with Tennessee gallop. So you see atrial way reflected, and it won't be normal, never physiological. Every case is pathological, and it will tell us about heart failure. And as you see here, S3 goes to the second sound. It will be diastolic gallop, and presystolic atrial gallop, you go to the next systolic period, S1. So what you will hear lab-da-da, and you will hear da-lab-da. And as you see here, we may compare them with the pronouncing of Kentucky and Tennessee gallop, which helps us to understand the heart failure. And in some severe cases, the combined presence of S3 and S4 forms the quadruple gallop, also known as hello goodbye gallop, and it tells us about severe heart failure and very high risk of dying of such a severe patient. And next, information associated with the murmurs, sounds resulting from vibrational vessels or structures of the heart due to the change of direction of blood flow or its strengthening. And as you see, normal walls, an exciting structure, and then you can see the destroyment walls by the acute rheumatic valvulitis, and also you understand that it can forms the abnormality of heart's melody. So main mechanisms of murmurs formation: acceleration of blood flow through the anatomical, normal or narrowing vessels, blood flow in the zone of expansion of the vessel or chamber of the heart, and reverse physiological blood flow, as you see here, named regurgitation through a leaky valve, septal defect, or valvular fistula. Let's go here, and in these pictures you see this mechanism of murmur's origin. And turbulence blood flow forms heart murmurs, and you see different shape of these murmurs. You can try to draw at your practical classes. So crescendo decrescendo, which is more typical for aortic stenosis and the most severe type of murmurs. Then decrescendo, typical for mitral regurgitation. Then pansystolic type of murmurs, typical for mitral or tricuspid severe regurgitation. And crescendo, you see here, tricuspid stenosis or mitral valve prolapse disorders. So, and you have to know how to identify systolic murmurs or diastolic murmurs by phonocardiogram. You have to apply it on the ECG graphic. And as you see here, after Curis complex or with it starts the systolic period and systolic murmurs. Then after the T wave, you receive the information about duration of diastolic period, and here you will see different types of diastolic murmurs. Let's go on, and you have to know that systolic murmurs may be functional or physiological, but never diastolic. And organic may be systolic and diastolic. And as you see here, special points you have to recognize. And you have to know that organic duration is more than half of systolic period, and functional are short oftenly. So then, as you see here, therefore, ergenic murmurs, irradiation typical, and these murmurs are stable as to different loud or respiratory tests. And the next intensity of heart murmurs, as you see here, grades, and you have to permit yourself to identify the grade and involve this information into the case history. And you see first grade only for trained ear, not for students, for your teachers. But then you go next grades, and you see here the murmurs became loud and maybe associate with palpable thrills. And as to the sixth grade, so it will associate with palpable thrills, but can be heard with a stethoscope lifted just off the chest wall. So let's go on. So abnormal chords as to the walls of the chambers of the heart may form these murmurs. And here is different types of onset of these murmurs, and they may be as systolic and diastolic types, and you have to identify that. But also you have to know the sites of murmurs radiation. So, for example, mitral regurgitation, you will hear at the apex, and radiation will be to the left axilla beneath left scapula. And for aortic stenosis, you will hear it maybe at the apex, maybe at the base of the heart. But look here, the murmurs will turn upper right sternal edge over carotids and so on for different type of murmurs. So let's look here, and as you see here, by the diaphragm, you may hear the systolic murmur of aortic stenosis, and better on the base of the heart. But then you will turn your stethoscope to the carotids, and you will hear these murmurs typical for aortic stenosis. Then look here, you auscultate by the bell apex and understand the tripled rhythm and systolic murmurs, and you go to the axilla and hear better on the left side this type of disorders. So there is the bell which can help you to identify the gallop, diastolic, third sound, ventricular gallop. So let's go on. And the rules for irradiation of the murmurs. The marked hemodynamic defect, the greater area of irradiation. The second rule, direction of irradiation consists with the direction of the blood flow. You see here, it's very important highlight from the place of origin of the murmur. The next, you optimize the auscultation and hear better the murmurs. Inhale, it's for right chambers of the heart. Exhale for the left chambers of the heart, because lungs will have help left ventricle to pump the blood to the vessels and to the body. Then loud. Then change of position, for example, forward or standing position. Then respiratory tests or pharmacological tests will help you also. And as you see here, inspiratory for right heart murmurs and deep exhalation for the left heart murmurs. So what we have to do: evaluation and identification of basic additional tones, verification of murmurs, dynamic auscultation with the tests, and then you have to make the conclusion about the auscultation of the heart. And you will use a bare position of your stethoscope, of membrane or the bell, but not through the sheets. So you have to remember this rule very well. And you have to use your brain to receive information and make the perfect conclusion. But for that, you have to understand that only practical skills and your practice at home, at the classes, in the wards may help you to be effective and to receive benefit. Thank you very much for your presence at this virtual short lecture. And you have to know that you may receive the full lecture at the site of the Department of Propedeutics of Internal Medicine. So be happy and be healthy.